Coronary microvascular dysfunction. The take-home message from this presentation is possibly, there will be methodological aspects that we'll talk about, but coronary microvascular dysfunction is massively underdiagnosed. And it contributes to many cardiac disease states, but we don't know necessarily that it's there if we're not measuring it. But it can be measured by most modalities and probably best with PET and CMR. And we're going to talk about this space now. So let's start by taking a step back and reflecting a bit about the overlap between coronary artery disease and heart failure. There are certainly people who have coronary artery disease without heart failure and heart failure without coronary artery disease, but there is a sizable overlap, as we're all too familiar. Now, overlaying on top of this, we have interacting pathophysiological characteristics. We have left ventricular hypertrophy, diastolic dysfunction, and coronary microvascular dysfunction. Now, this is, of course, a schematic slide, and I wouldn't go as far to say that these are proportional to any kind of quantification, but the principle is there that we have a large overlap of LVH, diastolic dysfunction, and microvascular dysfunction in both the heart failure and coronary disease cohort. And the reason we don't know exactly these numbers, at least when it comes to coronary microvascular dysfunction, is that it's not been systematically measured a lot. There are some studies, and we're going to talk about them. But there is certainly a big group, probably bigger than the area here in the middle, where we have all three pathologies in patients with both coronary disease and or heart failure. And I think it's worthy to take a moment and reflect on that we don't know it's there if we don't measure it. It's sort of like the unknown unknowns, if you will. But is it important? Well, it is associated with diabetes, hypertension, obesity, chronic kidney disease, the classic sort of comorbidities, but also female sex and age, but also other hypertrophies, LV hypertrophies, both hypertrophic cardiomyopathy, amyloid, Fabry, aortic stenosis. They all have components of coronary microvascular dysfunction, as well as a whole slew of other non-ischemic cardiomyopathies. So let's talk a little bit about how it's measured. In the cath lab, they use an alphabet soup of letters, FFR, CFR, IMR. Let's just take a moment to walk through those principles. Fractional flow reserve, FFR, is the ratio of the pressure distal to a coronary stenosis to the pressure before the stenosis. And that is assumed to be proportional to flow, which it often is, and it's sort of a relationship of flow across a stenosis. However, coronary flow reserve is more directly measure of flow, stress flow over rest flow. It can be measured in the cath lab, estimated as 1 over transit time. But that can give us a little bit more information that's not related necessarily to pressure. It's a flow measure. And then the index of microcirculatory resistance combines pressure and flow. So it's the pressure divided by the flow. When it says stress here, that's during pharmacological hyperemia, typically with adenosine. So we have pressure measures, flow measures, and combined flow and pressure measures. As we know, resistance is pressure over flow. So that's why this is often used for identifying coronary microvascular dysfunction. So you can have overlap of these disease states. In the top left, we have someone who has a stenosis and changes in his microvasculature, so a low fractional flow reserve indicating significant stenosis, high resistance indicating presence of microvascular disease, which is concomitant with a coronary flow reserve, which is reduced. On the other hand, you can have solely an epicardial stenosis, but a normal microvasculature. So only a reduction in the FFR, but normal resistance and normal flow reserve. Alternatively, you can have solely microvascular disease. So no stenosis that in the epicardial vessels, so that's the FFR is normal, but the resistance is high and the flow reserve is low. And then you can have some kind of mixed disease where even though there is mixed, the flow reserve will be normal, but the IMR may only be mildly elevated as opposed to severely elevated, concomitant with a reduction in flow reserve. So how does that translate to our non-invasive modalities? And that's what we're going to talk about. Here we see detection of coronary microvascular dysfunction by flow quantification with, in this case, rubidium PET. There's a couple different radio tracers that are used in the PET literature for flow quantification, rubidium being one of them. On the top here, we see the flow images. We have a CT that shows an absence of any obstructive disease. And at rest, they quantify the myocardial blood flow in the LV at 0.8 mils per minute per gram. At stress, it's a 1.3 mils per minute per gram, and that gives you a flow reserve of 1.6 stress divided by rest. And that is the definition of coronary microvascular dysfunction in the PET world, a flow reserve typically with a threshold of less than 2. In this case, 1.6 is certainly less than 2, and the absence of any focal perfusion abnormalities, the slightly lower values in the apex here being attributable to partial voluming. So it can be detected by PET, and then so how does that play out in the disease space? Well, here's a sizable study in Circulation back in 2014. Coronary microvascular disease dysfunction was found in 50% of males, 54% of females, and the prognostic association of having a coronary flow reserve less than 2 compared to one that was over 2 was a marked reduction or increase in major adverse cardiovascular events. And so the coronary flow reserve was strongly associated with events, but there was no strong association between males and females. There was no sex difference, as had been postulated by those authors and many others. How about pivoting into HFpEF? Well, here we see PET used to look at coronary microvascular dysfunction in HFpEF, where they used both a coronary flow reserve of 2 and an E over E prime of less than or greater than 15. And it was only those that had the double whammy, both the reduced coronary flow reserve less than 2 and the increased E over E prime, in this case septal E prime, greater than 15, that had the strong association with survival. Of course, there was a slight reduction for those that had, so coronary flow reserve here was the determinant. So it was basically the coronary flow reserve less than 2 that was driving the association with prognosis. And that's interesting that we assume that it's diastolic dysfunction necessarily that's driving the association with prognosis, and this data indicates that we might be of value to take into account the underlying pathophysiology, which may be manifested, as in this case, in coronary microvascular dysfunction in the setting of HFpEF. So can it be done with other modalities than PET? Well, this is a study with CT and water PET as the reference standard, so horizontal axis water PET, milliliters per minute per gram myocardial blood flow, on the vertical axis CT. And this is probably the best association I've seen. They developed their own CT post-processing algorithm. There are a bunch of commercially available solutions that have published data which don't look remotely this good. So a little bit of word of warning is the use of CT to quantify myocardial blood flow. Although there are examples of good associations like this one, there's some caution to what specific post-processing and acquisition protocol that you're using, because the devil is in those details, and it's not in favor of the routinely used software, although it's an emerging space, and I'm sure we'll have more to learn about that as time passes and development evolves. How about SPECT? Well, conventionally, SPECT or MIBI scans have not been able to quantify myocardial blood flow in mils per minute per gram, but with the new CZT detectors and the new SPECT detector technology, it is possible to quantify now. However, as you'll see here, horizontal axis PET blood flow versus on the vertical axis SPECT blood flow, there is an association which approaches a slope of 1 and a low bias, but the variability is sizable. Here, plus minus 95% confidence limits of over about 1.5 mils per minute per gram in each direction. So the work in the SPECT world has been promising with studies like this one, but it's not quite there yet, and there's some caution in the field, and it's not used routinely just yet. Certainly a research tool and evolving. In the world of cardiovascular magnetic resonance, the myocardial perfusion mapping has developed. Here's an example of a healthy individual with color-coded according to milliliters per minute per gram of tissue blood flow. At rest, 0.8 mils. At stress in a healthy individual, 4.9, a six-fold increase in normal reserve. Single vessel disease giving a perfusion abnormality, in this case in the right coronary territory, and microvascular disease giving a near homogeneous inability to increase blood flow with a factor, a reserve less than 2. So that's the kind of images we can get now routinely in clinical practice. No need for any kind of sophisticated manual post-processing. It's all fully automated and quantified at the time of scanning in quite optimized clinical workflow software that's now available. It's been validated to agree nicely, in this case with ammonia PET, with low variability and low bias. And then it's been taken to the cath lab as well and compared with things like the index of microcirculatory resistance, IMR. So here we have healthy volunteers, patients with quote-unquote normal physiology invasively, coronary microvascular disease by invasive physiology, IMR, and triple vessel disease. And they derived a cutoff as if the global stress myocardial blood flow is greater than 2.25, so not the ratio of stress to rest, just the absolute blood flow. That's normal. Coronary microvascular disease, if it's less than 2.25, and if it's really low, that's the kind we can see in triple vessel disease. And that's, I guess, a challenge. If you know already that the patient doesn't have triple vessel disease, then you can assume that any value under the 2.25 would be microvascular disease. And how does that pan out with survival studies? Well, they've also come out as such. This is published in Circulation fairly recently. Here we have stress and rest, basal, midventricular, and apical slice during adenosine stress. During rest, we have automatic AI-generated segmentation of the, according to the 16-segment model, and global quantification of stress myocardial blood flow. If it was greater than 2 or less than 2, we have this sizable difference in survival in a robustly powered cohort. So coronary microvascular disease by quantitative myocardial perfusion, CMR, is certainly has entered the building and into clinical use. Then we have some Doppler and echo methods you may or may not be familiar with. We can do transthoracic echo, LAD Doppler, for identifying coronary microvascular dysfunction. Now, given you're only going to be measuring in the LAD, and you're measuring the Doppler profile at baseline and during adenosine stress, and you can take the ratio of the stress to rest and get a coronary flow reserve of 2.9 in health, greater than 2, or in this case, going from 0.24 to 0.39, a ratio of 1.6 for the VTI envelope of the diastolic flow in the coronaries, and a less than 2 coronary flow reserve. And that's an interesting method because of its greater availability compared to PET and SPECT, but maybe not, you sort of need to know that the patient has the absence of stenotic disease, which may be known from an invasive coronary angiogram or a CT coronary angiogram, and you want, on top of that, want to identify but to confirm or rule out microvascular disease, or in this case, to do research. And here they showed in a study of in particular HFpEF, where it's particularly of interest, 75% had coronary microvascular dysfunction. It was showed an increased incidence of death or hospitalization for heart failure, or recurrent hospitalization for heart failure, or the composite of death and first hospitalization for heart failure, or first all-cause hospitalization, or any recurrent all-cause hospitalization. In every single case, there was a greater incidence of this among those that had coronary microvascular dysfunction identified by transthoracic Doppler of the LAD. It's increasingly being used, at least in the research space. And then finally, we have myocardial contrast echocardiography. I know I had a little chat with David Platz here before the talk. There may be some more recent developments in this. The problem with myocardial contrast echocardiography, at least as has been shown before, here we have the different contrast phases, and here we see the signal intensity over time developing, and that can be used to convert to a quantitative value, at least in the setting of identifying microvascular disease as opposed to overt stenotic disease and regional perfusion abnormalities, more global abnormalities, is you'll see the slope of this line. The horizontal axis here is PET. The vertical axis is the measure coming off of the echo. The slope of this line differs for, on the one hand, the LAD, on the other hand, the right coronary and the circumflex. And so it's not, you don't have the same post-processing rules or the same agreement with PET in different portions of the heart, which makes it a little bit more challenging to apply. And on top of that, there's a fair bit of variability in this. So when it comes to diagnostic precision, you want to know, it's all about the variability. And in this case, at least it's challenging in the setting of the 2006 comparisons to PET with the gold standard. David may come with some more information on that in the discussion. So a little bit of a comparison table for the different imaging modalities for coronary microvascular dysfunction. Here we have echo, CT, SPECT, CMR, and PET. From a cost perspective, again, not necessarily gospel here, but rough estimates based on what things cost outside of the business aspects. Echo would be the least expensive, but it's still more expensive than a single dollar because you have to at least pay for the adenosine. It's a little bit more cumbersome in the acquisition and requires a little bit more knowledge and experience for that, although it's eminently doable for someone that practices and learns how to do it. CT, SPECT, and CMR are all roughly in the same ballpark in their costs when it comes to doing these kind of exams, mostly driven by the added cost of adenosine. PET is slightly more expensive because of the radiotracer costs. Ionizing radiation, obviously absent in echo and CMR, but prevalent in SPECT, CT, and PET. Arguably, PET would probably have the lowest radiation burden because of this exquisite sensitivity for those tracers. The accuracy is decent for echo, decent for CT, but there are challenges for both of them, mostly attributable on the echo space to not coverage of the entire LV when you're just measuring in the LAD. SPECT probably has the poorest accuracy, and CMR and PET are now considered equivalent. When it comes to precision, there is a fair precision for both echo and CT, poor for SPECT, and also excellent for CMR and PET, likely mirroring the accuracy as well. Availability, echo obviously has a great availability if you possibly challenged by knowledge of the acquisition methodology of trying to find the LAD with the transthoracic probe. CT has low availability not because the scanners are less available, but rather because it requires special software and maybe the latest of the CT machines and experience with that on top of that. SPECT, there are lots of SPECT scanners, but maybe not that many of the modern day. Maybe that's arguably also a single plus there. I happen to put it too. CMR is not that great availability, and PET is also very limited in its availability. So echo certainly has availability going for it. When it comes to published data, there's fair amounts in echo, more so, absolutely more so in PET, and then CMR a close second. SPECT and CT are very limited in the data available. The main limitation being echo can only do the LAD. CT has an implementation challenge where it's not routinely available with validated, reliable software. SPECT is challenged by accuracy, MR by devices, as we saw the excellent image by Professor Hamilton Craig in the previous talk, and PET has its main limitation arguably in its availability, which is limited. So coming back to where we started, we have a large, considerable overlap in underlying pathology between heart failure and coronary artery disease, manifesting as the physiological characteristics that overlap in left ventricular hypertrophy, diastolic dysfunction, and coronary microvascular dysfunction. I don't know, but if I had the magic wand and or the crystal ball and had to predict where we're going, I would predict that we're going to see a greater focus on quantifying coronary microvascular dysfunction to identify it and either address it and try to treat it with trials aimed at pharmacological therapy to ameliorate that, as well as trying to rule it out. Say, oh, this chest pain is not coming from epicardial coronary disease. It is not coming from microvascular disease. It's something else. Today, it's more of a diagnosis of exclusion to say, oh, we don't have any epicardial coronary disease, so it must be microvascular disease, likely, but we don't know. We're not sure how to treat it. There's a lot of space for improvement on the treatment side, but only once we know that it's there or not by diagnosing it. So in summary, coronary microvascular dysfunction is massively underdiagnosed. It's a large opportunity for us in the non-invasive imaging space to up our game, to learn more about its prevalence and pathophysiology and potential treatments. And it contributes to many contributes to many cardiac disease states. And it can be measured by most modalities, but arguably best with PET and CMR in its current embodiments. Thank you very much for your attention.